Okay, we'll get going. Okay, good evening, everybody. Welcome to this another session of 45th Comprehensive Course on Echocardiography. We have with us very learned speaker, Dr. Debika Chhaterjee from Calcutta. She is the head of a department of non-invasive cardiology at Narayan Hridayalaya, Rabindranath Tagore Institute of Cardiac Sciences based at Calcutta. Many of you have heard her before, and she's those versatile speaker, and she's going to deliver on the most important part of any echocardiography, that is diastology. What is diastology? It's relaxation, and it's not relaxation which is not energy dependent. It's truly an energy dependent process, which she is going to dwell on in next 45 to 50 minutes. With this few words, let me turn over a mic to Dr. Debika Chhaterjee to talk on this particular phenomena of diastolic function evaluation. Dr. Debika, it's all yours now.
Thank you, sir, for the kind introduction. And hi, everybody. Good evening. I'm going to talk on diastolic function and its assessment by echocardiography. Let's start with the patient who is 60 years old, male, obese with history of hypertension, presented with progressive exertional dyspnea with fatigue. And on examination, you get bilateral ankle edema, hepatomegaly, bilateral crepes, all signs of congestive heart failure. Now, what is the cause of this congestive heart failure? We have a habit of thinking about the systolic heart failure always for the cause of congestive heart failure. And we do the echocardiography to see how the LV is functioning, how much is the ejection fraction. And we find there is no wall motion abnormality. LV is contracting very well with the ejection fraction of 65%. But as we do the Doppler echocardiography, after ruling out left to right shunt, right heart pathology, we find that the patient is having diastolic dysfunction with elevated LV filling pressure. So this patient is basically in diastolic heart failure with preserved ejection fraction, which accounts for 40 to 50% of all heart failure. So this we say HEPF, heart failure with preserved ejection fraction. You must have heard about this. And it's responsible for significant morbidity, mortality, and recurrent hospitalization. And the prognosis is as bad as systolic heart failure. So we need to know about the diastolic heart failure. We need to know how to decipher the diastolic dysfunction in these patients. When a patient comes with heart failure, we need to answer a few questions. Like, does the patient truly have the heart failure with preserved ejection fraction? Or the patient's shortness of breath is due to some other pathology, which might be cardiac or non-cardiac. We also need to know the hemodynamics of the patient to optimize the unloading therapy. And also, we need to risk stratify the patient. We need to estimate the prognosis. And all these questions can be answered while assessing the diastolic function by echocardiography, because echocardiography not only gives us the information regarding the structural problems, but also gives us the functional problem regarding the LV filling pressure, which is elevated in diastolic heart failure, because it's the final common effect of diastolic dysfunction. And it is the elevated LV filling pressure which results in shortness of breath in HEPF, and it's a marker of poor prognosis. And moreover, as per the latest American Society of Echocardiography guidelines, the grading of diastolic dysfunction is based on the presence or absence of elevated LV filling pressure. So we need to we need to know how to assess the diastolic dysfunction in details, including how to estimate the LV filling pressure while assessing the diastolic dysfunction. So your diastology echo report should contain not only about the presence of diastolic dysfunction. You also need to make a comment on the status of LV filling pressure, whether it's normal or it's elevated. Now, a bit about the physiology of diastole, which is it's a phase of someone's mic is on. Could you please switch off your mic? Diastole is the phase of filling. It starts with aortic valve closure and ends with mitral valve closure. And it is the process by which heart returns to its relaxed state. And if we look at the phases of diastole, it starts with isofolimic relaxation phase. What happens during that phase? There is active myocardial relaxation and elastic recoil by removal of calcium ion from troponin C, as a result of which myocardium undergoes relaxation. And due to this relaxation, the ventricular pressure. Hello. So that results in the lowering of the pressure inside the ventricle. So a time comes when the ventricular pressure is below the left atrial pressure, and that results in opening of the mitral valve. And as soon as the mitral valve opens, a gush of blood from the left atrium goes to the left ventricle, that we say early rapid filling. It is the during the early rapid filling phase we get the E wave. मैंने कुलदीप को फोन कर दिया, वो ओटी टेक्नीशियन है तो उसका फोन आ गया था, बता दिया मैंने। Early rapid filling phase we get the E wave, and then after the 80% filling of the left ventricle during early rapid filling phase, a time comes when the left ventricular and the left atrial pressure becomes equal. There is no active movement of the blood from the LA to the LV, and that phase is called diastasis. Now the rest 20% of the blood which is remaining in the left atrium is ejected to the left ventricle by atrial pump, or we say left diastolic filling phase. So that gives the A wave during the atrial contraction. So if we look at the phases, there are two factors which are actually responsible for normal diastole. One is the relaxation of the myocardium. As I say, there is removal of the calcium ion from the myocardium, and myocardium relaxes. And next is the compliance. Compliance is the, this is the filling phase. So LV has to undergo, LV should be compliant enough to receive that whole amount of blood. So it's the distensibility of the relaxed ventricle. It's the response of the ventricle volume in change of pressure. Stiffness is the opposite word for compliance. Now, if both these two factors are normal, then you have a normal diastole where there is adequate LV filling without increased LV filling pressure at rest as well as exercise. But if there is impaired relaxation or there is reduced compliance of the LV due to stiffness, what will happen? There will be impairment of the LV filling diastole, That will result in increased pressure in the LV and increased LA pressure. With LA remodeling, LA undergoes dilatation. That results in the back pressure, resulting in pulmonary venous hypertension, and patient goes into heart failure, and that is the cause of diastolic heart failure. If we look at the causes of diastolic dysfunction, there are many causes. The old age tops the list. You see, we know there are certain changes which are associated with aging process in the heart and the vascular system, which occurs normally in an old patient. And one such is the impaired myocardial relaxation. And that gives rise to the diastolic dysfunction in an aged patient. So diastolic dysfunction due to impaired relaxation is a normal finding in an aged patient, in a 60 years old. But if that same finding we get in a patient of 35 years, it's abnormal. So age should be taken into consideration while evaluating diastolic function. The next important cause is long-standing hypertension. Cardiomyopathy of any type, be it hypertrophic, restrictive, or infiltrative, gives rise to the diastolic dysfunction because these are the myocardium which cannot relax. The coronary artery disease, ischemic myocardium, or a scarred myocardium cannot relax and gives rise to the diastolic dysfunction. Extrinsic cause like constrictive pericarditis can give rise to the diastolic dysfunction, so also obesity and the sleep apnea. Now, we always start with two-dimensional echocardiography while assessing the patient for diastolic dysfunction. Now, what are the information we get from the 2D echo? It is the objective evidence of structural cardiac problem. Suppose you do the echo, and in the parasternal long axis you see this. See, this is a case of asymmetrical septal hypertrophy. Or if you look here, this is a patient where there is a large infarction in the LAD territory. So we know hypertrophic cardiomyopathy or ischemic myocardium cannot relax. So these are the patients which will have the diastolic dysfunction. So this is the objective evidence from 2D echo. And another very important 2D echo parameter for assessing the diastolic dysfunction is enlarged LA. Because as I said, if you look at the pathophysiology of diastolic dysfunction, as a response to the raised LV filling pressure, the LA undergoes enlargement. So it's a sign of chronic marker of LV filling pressure. And it's a very robust indicator of diastolic dysfunction with elevated LV filling pressure. And of course, in absence of anemia, atrial fibrillation, or mitral valve disease, or even in athletes. And because in these cases, even if there is no diastolic dysfunction, you may see the enlargement of the left atrium. So, enlarged LA is a chronic marker of raised LV filling pressure. Now, how we are going to measure the left atrium? We always start measuring at the left atrium in the parasternal long axis, where we measure in two-dimensional view, starting from the trailing edge to the leading edge, and these are the values for normal LA. Now, you know that this is the measurement, anterior-posterior measurement. Now, LA is a chamber. It's a three-dimensional structure. Heart chamber is a three-dimensional structure. It has not only the anteroposterior diameter, it has, superior to inferior diameter, medial to lateral. It's a three-dimensional chamber. So, if you measure the anteroposterior linear dimension, this is not enough. As per the AAC guideline, you need to measure the LA volume and you need to index it to the body surface area. It has to be done by the biplane area length method, where we use the AP 4 chamber, apical 4 chamber, and its orthogonal view apical 2 chamber. Now, how we measure the LA here? We are going to measure the area and the length by which we'll get the volume. Now, in AP4 chamber, say we start with the AP4 chamber, we freeze the image. Then with the trackball, we choose a frame which is 1 to 2 frame before the mitral valve opens. That means that time the LA is in its full volume. The ventricle is in systole just before the mitral valve opening. When the ventricle is in systole, LA is in diastole, so LA will be in its maximum volume. So we choose that way, looking at the ECG, or you look at the LA where there is maximum, and then start tracing from one annulus, septal annulus, then go along the endocardial margin of the interatrial septum, then go along the roof of the LA, and then up to the lateral annulus. You should never go inside the pulmonary vein. Inside the pulmonary vein. Hello, আমি একটু ক্লাস নিচ্ছি, একটু পরে ফোন করবো, হ্যাঁ? So you need to you should be careful not to go inside the pulmonary vein, and also the LA appendage. So here you get area 1, and also you get a caliper where you
Dr. Arfan.
That is the midpoint of the interannular line. There's the maximum diameter for the length. So in apical 4 chamber, you get an area and a length. Then next you go to the apical 2 chamber view and repeat the same process, where you get area 2 and the second length. So the formula for the LA volume is 0.85 into area 1, which we got from the 4 chamber view, multiplied by area 2, which we got from 2 chamber view, divided by length. Now, there are two values of length. Which one we are going to take? We are going to take the shorter value. If suppose this is 5.4 and this is 5.3, we are going to take 5.3. Now, you need to take care of the fact that these two length, the measurements of this length and this length should not, the difference should not be more than 10%. If it is more than 10%, then an error comes. So you need to repeat the procedure from the beginning. So the difference in these two measurements should not be more than 10%. So after putting these values of A1, A2 and shorter length, you get a LA volume figure, and then you divide that value with the body surface area of the patient, which is obtained by the height and weight. And the upper normal value is 34 ml per square meter body surface area. Any value above 34 is considered as dilated LA or enlarged LA volume. Look at this. This is a patient where I have measured the anteroposterior diameter of the LA, and this comes as 3.61 centimeter. 3.61 centimeter is within normal limit, but as I measured the volume, I found that LA volume index was 35 ml per square meter of the body surface. This is the reason you should not take the anteroposterior diameter and rely on that. You need to measure the LA volume. It happens so that LA in some cases remains normal in the anteroposterior direction, normal in size, normal in diameter, but it enlarges in the medial to lateral direction. So those are the cases where we will miss that the LA is enlarged if we only measure the anteroposterior diameter. This is the reason we need to measure the LA volume. Okay, clear? Now, next, we will go to the mitral inflow pattern for assessment of diastolic function, which is very, very important. Here, what we do, we go to the apical four-chamber view, put the color flow, and get the cursor and place the sample volume at the level of the tip of the mitral valve leaflets. Not inside the ventricle, not inside the left atrium, but at the level of the tip of the mitral valve leaflets, which is the correct position. You see here? Now, with the sample volume at the level of the tip of the mitral valve leaflets, we do the pulsed wave Doppler. As we do so, I already explained you while explaining the physiology of diastole that the fast wave is the E wave, which happens during early rapid filling phase, and the second wave is the A wave, which occurs during late rapid filling phase, and this is the diastasis. And E wave is normally more than A. Now, as the diastolic dysfunction sets in with impaired relaxation, what happens? Because of the impaired relaxation, LV pressure fall is slow. So, the mitral valve takes time to open, but when it opens, the difference of pressure between LA and LV is not very high because myocardium relaxation is poor. So only a small amount of blood flows from the LA to LV, resulting in smaller E wave. See, E wave. So the 80% filling was taking place during early rapid filling phase in normally, whereas only 20% of the filling is taking place during early rapid filling phase when there is impaired relaxation. And the most of the filling is taking place during the late rapid filling phase by the atrial contraction. Now, as time goes and diastolic dysfunction advances, a time comes when the LA pressure gradually rises. So when there is moderate rise of the LA pressure, what will happen? Again, the pressure difference between LA to LV will increase, and that will result in increase in the E wave velocity. So the pattern again becomes like normal, though it's not normal. Over the impaired relaxation pattern, there is a raised LA pressure, which has resulted in a bigger E wave than A wave. This pattern is underlying these, but it is because of the raised LA pressure, the E wave again becomes taller. Now, with further advancement of the diastolic dysfunction, the LV will become stiff. Not only the impaired relaxation, LV also becomes stiff, LA pressure significantly rises. So what will happen? The very high LA pressure, the E wave will be very tall. The pressure difference between LA and LV is very high. So that gives rise to very tall E wave. But we know that LV compliance is low in this stage. So what will happen? There will be quick equalization of the pressure between LA and LV. So that will result in quick deceleration of the blood. And the A wave Though the LA pressure is very high, but still that high LA pressure cannot pump the blood to the LV because the LV compliance is poor. It is like a balloon made of thick rubber. So, normally the balloon inflates when you apply some, you introduce some air. But here in this case, now if the balloon is made of thick rubber, even if you pump air, the balloon will not inflate. So that thing is happening here. The LV walls are stiff, just like the thick rubber. So it's non-compliant. So though the LA is pumping very hard, but LV cannot receive the blood, and that results in a very small A wave. So very tall E, short deceleration, and a small A is the finding of very advanced diastolic dysfunction, the mitral inflow pattern. So what I said, the relaxation abnormality is present in all grades of diastolic dysfunction. It is by the raised LA pressure that the pattern is changed here and here because of raised LA pressure along with non-compliance of the LV. Now, if we look here and here, the patterns are same, but one is normal, another is not normal. We say it pseudo-normal. How do you differentiate? Now, look, this is a person who came for a routine heart checkup, keeping the sample volume at the level of the mitral valve leaflet tip. I get a mitral valve forward flow where E wave is more than A wave, E ratio is 1.7. So these I say normal. But look at this patient. This is a patient of hypertrophic cardiomyopathy. Look at the IVS, it's so thickened. Look at the LA, it's so much dilated. But keeping the sample volume at the level of the tip of the mitral valve leaflets, again I get a pattern where E wave is more than A wave. So do you think this is normal? Looking at the cardiac structure, do you think this is normal? No, this can't be normal because it's a case of hypertrophic cardiomyopathy. This myocardium cannot relax. The LA is enlarged, so obviously the LA pressure is raised. So this is pseudo-normal pattern. So now, how do you differentiate these two patterns? By doing the pulse wave Doppler, you cannot differentiate. So which are the maneuvers, which are the process by which we can differentiate a normal from a pseudo-normal pattern? One such is the Valsalva maneuver, which is a preload reduction maneuver. We know that LA pressure is raised, which gives rise to the bigger E wave than A wave. So by asking the patient to do the forceful expiration with mouth and nose closed, and another is tissue Doppler imaging of mitral annulus. Now first, let us see when we ask the patient to do the Valsalva maneuver, what happens to the mitral inflow in a normal patient having normal filling pattern. See, this is the normal, E is more than A. I ask the patient to do the Valsalva. He starts doing Valsalva from here. Look, the velocity of both E and A wave are reduced, keeping the ratio same. E is more than A, but the velocity of both E and A are reduced. So that particular normal patient with Valsalva maneuver showed this pattern. On the other hand, look at that case of hypertrophic cardiomyopathy. This is the pattern which we got, E wave more than A wave. Now I ask the patient to do the Valsalva, which is a preload reduction maneuver. This pattern goes back to the impaired relaxation pattern where E wave is less than the A wave. So as I have obliterated the unmasked, the raised LA pressure, the pattern has gone back to its impaired relaxation pattern. So this pattern we say is pseudo-normal filling pattern. After the Valsalva maneuver, we can also differentiate with tissue Doppler imaging. So what is that tissue Doppler imaging? So long we were measuring the velocity of blood flow, keeping the sample volume at the level of the tip of the mitral valve leaflets. But this time we are going to measure the velocity of the tissue. Which tissue? In this case of assessment of diastolic dysfunction, we measure the velocity of mitral annulus. First the septal annulus, then the lateral annulus. So how we do it? We switch on the tissue Doppler imaging in the apical four-chamber view, and then we reduce the width of the sector to increase the frame rate. This is the septal annulus. We place the sample volume cursor, the sample volume of the cursor at the septal annulus, and get the pulse wave Doppler. See, this is the way we do. This is the normal patient. E was more than A, and look at the tissue Doppler imaging of septal annulus. We know that annulus moves during systole, it moves towards the apex, and during diastole, it moves away from the apex. So this is the baseline, yellow line. Above the baseline are the systolic waves, and below the baseline are the diastolic waves. If you look at the diastolic waves, because we are concerned about the diastole, so look at the diastolic waves. The first big diastolic wave is called the E prime, and the second diastolic wave is called the A prime, big wave. And you look here, E was more than A. So also in the tissue Doppler, E prime is more than the A prime in the septal annulus, as well as at the lateral annulus. E prime is bigger than the A prime. On the other hand, look at that patient of hypertrophic cardiomyopathy, where E wave was more than the A wave. But as I do the tissue Doppler, look, E prime is much less than the A prime. It gives the true picture of diastolic, diastolic dysfunction. In the septal annulus, E prime is less than the A prime. So also in the lateral annulus, E prime is less than the A prime. So tissue Doppler imaging will never let you down. The pulse wave Doppler will give you the masked information when E wave will be more than A wave, though the patient is having diastolic dysfunction. But the tissue Doppler gives the true image where E prime is less than the A prime. Now, when I talk about the tissue Doppler imaging, you must remember that there is a value called ratio of E by E prime, which can predict the LV filling pressure. So E means the pulse wave Doppler of the mitral forward flow, and E prime is the tissue Doppler imaging first diastolic wave. So how do we do that? We do the pulse wave Doppler, measure the E velocity, and then we do the tissue Doppler imaging. We measure the E prime, first of the septal annulus. We divide the E by E prime of septal annulus. We get a value. Here in this case of hypertrophic cardiomyopathy, the septal annular E by E prime was 24.75, and in the lateral annulus E by E prime was 15.5. And we do the average of E by E prime, and that turns out to be 20.12. Now, as per the latest AEC guideline, the average E by E prime equal or more than 14 predicts raised LV filling pressure. So this E by E prime value can predict the LV filling pressure, and we do it in this way. Another value also is important to indicate the status of LV filling pressure, which is the Tricuspid Regurgitation Jet. This is the four-chamber view. This is LV, LA, RV, RA. And if you see, there is a small tricuspid valve regurgitation. That blue color denotes the regurgitation. Red is the forward flow. Now I place the cursor along the tear jet, and I do the continuous wave Doppler where the tear comes below the baseline. I measure the peak velocity of the tear, which turns out to be 3.15 meter per second. That gives a gradient of 39.7 millimeter. Roughly, it's 40 millimeter of mercury. 1 second, please. So it's 40 millimeter of mercury. Now, normal peak tear jet velocity should be less than 2.8 meter per second. Here I got 3.15 meter per second. So it indicates the raised pulmonary arterial systolic pressure, because with this tear jet gradient, we add the RA pressure. Tear jet gradient is the pressure difference between the RA and RV. So if we add RA pressure with the tear jet, we get the pulmonary RV systolic pressure, which is equivalent to the pulmonary arterial systolic pressure in absence of pulmonary valve stenosis. So for knowing the RA pressure, we look at the IVC, and that I will tell you in another class. If IVC is normal in size, collapsing normally with respiration, we add 3. So with 40, we add 3 and get the pulmonary arterial systolic pressure, which is 43 millimeter of mercury, which is high. And that raised pulmonary arterial systolic pressure from the tear jet indicates elevated LV filling pressure. So the signs of raised LV filling pressure from two-dimensional echo is the dilated left atrium, raised LA volume index. Then we got the E by E prime, and also we got the TR jet gradient. Now, the parameters which we use in the assessment of the diastolic function, till now you have seen LA volume index, velocities of E and A, EA ratio, septal and lateral annular E prime velocities, E by E prime ratio, and tear jet velocities. Now the question is how we grade the diastolic dysfunction. If a patient comes with myocardial disease, having normal or reduced ejection fraction, if the EA ratio is less than 0.8 or equal, plus E wave velocity less than or equal to 50 centimeter per second, straight away you can say the patient is having normal LA pressure, which means normal LV filling pressure, and it is grade 1 diastolic dysfunction. Let's look at this patient. This is a patient who is 60 years old male, came for a routine checkup with a history of hypertension for 1 year, but non-diabetic. And I measure the mitral inflow pattern, where I see that E wave velocity is 48 centimeter per second and EA ratio is 0.6. So as per the AEC guideline, LV filling pressure is normal or low if E velocity is less than 50, as I say, plus EA ratio is less than 0.8. And we say it grade 1 diastolic dysfunction. And we check the LA volume index of this patient. We see that LA volume index is normal, 28 ml per square meter. And we also check the E by E prime. We find out that average E by E prime is 7.4. So our finding of mitral forward flow, the velocities and the ratio goes pretty well with the findings of LA volume index and E by E prime. So it's grade 1 diastolic dysfunction with normal LV filling pressure or normal LA pressure. Then next is another group where if we get E by A ratio more than 2, straight away we can tell that it's a grade 3 diastolic dysfunction. Having raised LA pressure, that means raised LV filling pressure. Look at this patient. A 56 years old male, hypertensive, non-diabetic, complaining of shortness of breath. He's in class 2 to 3 for last 6 months. Get bilateral ankle edema, hepatomegaly, and bilateral basal crepes on examination. Look at the LV. Look at the LA. Look at LV. LV myocardium is thickened and it's glistening. It's a case of cardiac amyloidosis. Look at LA. LA is so big. And then I measure the E and A ratio. I find that it's 6.6. Look, tall E, short A. A is almost not there. So as per the latest AAC guideline, the LV filling pressure is elevated if the EA ratio is 6.6. And it's grade 3 diastolic dysfunction. However, you must remember that this patient is a patient of cardiac amyloidosis. You may get to see similar pattern, very tall E, small a, in the healthy young individuals having no myocardial disease and normal LV ejection fraction. So you must be very careful to make a comment of grade 3 diastolic dysfunction in an young adult. If happens to be normal, healthy young individual, then this pattern is normal. This is the pattern if you get in a patient with myocardial disease, then only you are going to tell that it's a case of grade 3 diastolic dysfunction. Clear? We measure the LA volume index of this patient. It's 42 ml per square meter. And then we measure the E by E prime. And it turns out to be average E by E prime 44.6, which is very high. So it's a really grade 3 diastolic dysfunction. However, we get to see many patients who fall in these group, where E by A is though less than 0.8, but E wave is more than 50 centimeter per second, or E A ratio more than 0.8, but less than 2. So these are the patients which fall in between left arm and the right arm. So you see, this is the situation 1. This is a patient of hypertrophic cardiomyopathy, another patient with an enlarged LA. You are getting E wave less than A wave, but it's not fulfilling the criteria of grade 1. It's coming in between, where EA ratio is less than 0.8, it's 0.7, plus E wave velocity is more than 50 centimeter per second. Here it is 99 centimeter per second. Here we cannot say, cannot make comments on the grade of diastolic dysfunction by looking only at these mitral valve inflow pattern. Here, because we cannot make comment on the LV filling pressure of this pattern of diastolic filling pattern, we cannot comment on the grade of diastolic dysfunction. We need some additional parameters to comment on the LV filling pressure. Or situation 2. Let us see what is the situation 2. EA ratio is more than 0.8 but less than 2. This is a patient, you see, who had a infarction in the LAD territory, we look at the thrombus and there is a thrombus and it's akinetic. So a case of myocardial infarction in the LAD territory is showing the E wave taller than A wave with a ratio of 1.38. So it comes between here again uncertain LV filling pressure and the grade of diastolic dysfunction. We need additional parameters to comment on the LV filling pressure. Now, what are those additional parameters? Average E by E prime that we have already learned. If it is more than 3, it's a positive criteria. TR velocity, I have already discussed. If it is more than 2.8 meter per second. And the LA volume index, if more than 34 ml per square meter. These are the 3 criteria which are to be seen for classification of this group of patient. If out of these 3 criteria, all 3 are negative or 2 are negative, then we say it's grade 1 diastolic dysfunction. You are not these criteria are not fulfilled, or 2 are not fulfilled, then we say it's grade 1. But if 2 out of 3 or 3 out of 3 are positive, fulfilling the criteria, then we say it's grade 2 diastolic dysfunction. But if there are only 2 criteria, okay, let us see this case. Look, here E by A, that same patient, it's 0.7, E velocity is 73.8 centimeter per second. We are getting average E by E prime 20, so it's a positive criteria. See, it's a positive criteria. Then next I go to the TR velocity. I get a TR velocity of 1.48 meter per second. So it's not fulfilled. Then next I go to the LA volume index. And I find that LA volume index is 35 ml per square meter. So it's positive. So out of 3, 2 are fulfilled. So it's a grade 2 diastolic dysfunction. Now, if, see, it's a grade 2, 3, out of 3, 2 are positive. So it's a grade 2 diastolic dysfunction. And there is a group, if you get only 2 criteria. In many patients, we don't see the TR velocity. The TR jet is not present. You are getting only 2 criteria, E by E prime and the LA volume index. Out of those 2 criteria, if 2 are negative, you say it's grade 1. If 2 are positive, you say grade 2. But if there is only 1 positive, 1 negative, you cannot determine the class of diastolic dysfunction. You can only say it's diastolic dysfunction present, but you cannot say whether it's grade 2 or grade 3 or grade 1. So those are the patients where we do pulmonary venous flow pattern. Look, this is the apical 4-chamber view. I put this color in the pulmonary vein. This is the right upper pulmonary vein entering into the left atrium. Can you see this red color? I place the sample volume deep inside the pulmonary vein and get the pulse wave Doppler. Now, normally it's a venous flow. In the pulmonary vein, there is a systolic wave, then there is a diastolic wave. And during the atrial contraction, from the atrium, some blood goes to the LA and that gives the atrial flow reversal. But anyway, if you look at the systolic wave, it's bigger than the diastolic wave. But if there is a patient with reduced ejection fraction, as in this case, a large LAD infarction, so the patient's ejection fraction is definitely low, and you are getting systolic wave less than the diastolic wave, we say that this is a sign of LV, raised LV filling pressure. However, this is not applicable in healthy individual with normal LV ejection fraction. Remember it. Another very important criteria for assessment of LV filling pressure is isovolumic relaxation time. So what is that time? It is the time from the aortic valve closure to the mitral valve opening time. So it is a phase of diastole, as I said, during this time the myocardium undergoes relaxation, as a result of which LV pressure falls. So it's the time when AV valve also is closed, mitral valve also is closed. And normal value is less than 70, equal to or less than 70 millisecond. And it is inversely related to the LV filling pressure. If the LV filling pressure rises, then it shortens. And if LV pressure is normal, it gets prolonged. I mean, when it is prolonged, LV filling pressure is normal. When it is short, it's raised. Because of what you know. See, if the myocardial relaxation is initially poor in the grade 1 diastolic dysfunction, mitral valve will take longer time to open. So that will cause, in the grade 1 diastolic dysfunction, prolonged IVRT. But in the second stage of the diastolic dysfunction, when the LA pressure rises, because of the rise of the LA pressure, the mitral valve opening again becomes quick. Though the relaxation is poor, but it is the raised LA pressure which opens the mitral valve that shortens the IVRT. So IVRT is inversely related to the LV filling pressure. Now, how do we do that? We go to the apical 5-chamber view. You see, this is the left atrium, left ventricle, and we have opened up the aorta. And this is the mitral valve opening and closing. Now we get the cursor and place the sample volume in between the mitral valve and the aortic valve, so that when we do the pulse wave Doppler, we get to see the mitral inflow above the baseline as well as the aortic outflow, LVOT flow below the baseline. Now we know that this is the end of the aortic forward flow. It starts from here, it ends here. But there is a gap before the mitral valve opens. So that is the time of isovolumic relaxation. You see, we measure this time, and in this case, IVRT is 66.54 millisecond. So 66.54 millisecond is a normal finding. Now, IVRT, if it is less than 65 millisecond, in a case of a patient with myocardial disease, it indicates raised LV filling pressure in presence of atrial fibrillation. Another criteria is the colored M mode propagation velocity, or VP, we say, propagation velocity, or velocity propagation. Now, what it is, try to understand. Now, when the blood flows from the left atrium to the left ventricle, in a normal heart, where there is normal relaxation and normal elastic recoil, the blood, as soon as the mitral valve opens, the blood is sucked into the left ventricle, because there is a pressure difference between the base and the apex. So the blood moves very fast from the base to the apex of the left ventricle. Now, keeping the cursor at the middle of the mitral forward flow, instead of getting pulse wave Doppler, if you get the M mode pattern, the picture will be like this. So this is the line, this is the level where the mitral valve is seen. Can you see that white is structure? And this is the forward flow of the blood. And we look at the slope of the forward flow. Normally, it should be very steep. because normal relaxation of the LV myocardium is very strong and blood moves very fast from base to apex, from base to apex. It moves very fast. And what we do, we place a point at the level of the mitral valve and follow this slope and go 4 centimeter inside the left ventricle. This is the left ventricle. So this is obviously the left ventricle, where we are following the slope of the blood flow, and we measure this slope. And it is denoted as VP. Normally, it is more than 50 centimeter per second. It's a velocity, so it comes in centimeter per second. It's more than 50. But in all other 3 grades of diastolic dysfunction, it is below 50. Now, what is the importance of this value? So now it has been seen that if you take a ratio of E by VP, and if it is more than 2.5, it predicts pulmonary capillary wedge pressure more than 15 in patients with reduced ejection fraction. And E by VP more than or equal to 1.4 indicates raised LV filling pressure in atrial fibrillation. Because estimation of diastolic function in atrial fibrillation is very challenging because we don't have a wave in atrial fibrillation. So we try to find out some other ways. These are the ways by which we can estimate the diastolic function, grades of diastolic dysfunction. Because E by VP more than 1.4 indicates raised LV filling pressure in atrial fibrillation. But of course, this method has got lower feasibility and lower reproducibility. Now, till now, we were discussing about the diastolic function at rest. Patient was lying on the bed and we were trying to assess the diastolic function. Now, look at this group. This is, I said it's grade 1 diastolic dysfunction, having normal left atrial pressure, normal LV filling pressure, but still they become symptomatic when they do the exercise, say walking. Look at this patient. After walking for a while, the patient becomes short of breath, but at rest, he is fine. So this is the group where we should, though the LA pressure and the LV filling pressure is normal, we should consider about the coronary artery disease, or we should proceed for diastolic stress test. What is that? Diastolic stress test is the measurement of the LV filling pressure by echocardiography when the patient exercises. Till now, we are measuring the LV filling pressure when the patient was lying on the bed at rest. Patient was at rest. But we will be measuring the LV filling pressure now with exercise. Why? Because look at this graph. In a normal person, whether at rest or the patient does the exercise, the LV filling pressure, LV EDP is normal. This is the 15 millimeter of mercury at rest as well as at exercise. Well, in advanced HEP patient, even at rest, the LV filling pressure is high and it will go higher as the patient walks. We got in advanced HEP patients, high LV filling pressure at rest. Now, what about this group of patients whose LV filling pressure is normal at rest, but as the patient starts walking or doing exercise, his or her LV filling pressure rises. So these are the patients who are in the early HEP, and we are going to measure the LV filling pressure. Now, why does it happen? What is the effect of exercise on diastolic function of the heart? Now let us look at the normal subject. Now as the patient exercises, there is an augmentation of the myocardial relaxation with more powerful early diastolic suction. Early diastolic suction. And that will increase the E velocity as well as the E prime velocity. And that will keep the E by E prime ratio normal, which indicates normal LV filling pressure. So in normal subject, there is no problem. But in that particular early HFpEF patient, where there is normal LV filling pressure at rest, but rises as the patient exercises. Why? Because in this particular group of patients,
उसके बाद उस दिन मेरे को फोन करके पहले तो हमारा मिलना होता था नहीं ठीक है उसके बाद फोन करके मुद्दा पूछती है कि क्या हुआ कितना करता हूँ
there is no augmentation of myocardial relaxation, and the required cardiac output is achieved at the expense of increased LV filling pressure. What will be the result? Though the E wave will be increased, but since there is no augmentation of the myocardial relaxation, there is no change in the E prime, and that will result in high E by E prime ratio, which indicates the raised LV filling pressure, and that results in shortness of breath. So how do we do that in our lab? See, that is called the exercise stress echo. So what is that? So at rest, first we take the diastolic parameters. You do the E wave, E by E prime, L volume index, everything. And then patient starts walking on the treadmill and does a symptom limited exercise. As soon as the patient becomes short of breath, patient lies on the bed. Immediately at the end of the exercise on his or her left lateral position, and we start taking the diastolic parameters again. Now, initially, the E and A wave will remain fused together because of the tachycardia. But a time comes within a minute or 1.5 minutes when the heart rate comes down, EA becomes separated. You start acquiring the images that time. You measure the E wave, A wave ratio, E by E prime. And what is the result? You see, this is at rest, E, A. And at stress, E wave becomes taller than the A wave. But look at the E prime. At rest, E prime was bigger than the A prime. But at stress, E prime again has become smaller further from 7 centimeter to the 6 centimeter, making the E by E prime ratio of 17.6 at stress instead of 9 only at rest. So this is the reason why the patient becomes short of breath when the patient walks. So this is the patients who are fit for diastolic stress test, and that will reveal the cause of their shortness of breath with this test, and we can label this group of patients as early HFpEF. Another method by which we can also assess we can reveal the LV filling pressure by doing the passive leg raising test. What do? We are doing the diastolic function assessment at rest. Patient is lying on the bed. Now we will elevate both the legs passively. What will do that? Because of the elevation of the legs, it will elevate the preload. It will increase the preload. And as soon as the preload increases, that will unmask the elevated LV filling pressure, and E by E prime will be higher, which was normal at rest. After raising the leg, because of the increase of the preload, E by E prime will be increased. And there is a favorable advantage in this patient, in this test, because patient doesn't do the exercise, so there is no chance of become tachycardic. The E and A wave remains separated, so you can easily measure the E by A prime. Now, there are advanced techniques for assessment of diastolic dysfunction which are coming, like volumetric analysis of the LA by 3D, LA strain and strain rate measurement by speckle tracking echocardiography, global longitudinal strain, global longitudinal diastolic strain, LV untwisting rest. So there are many advancements, rapid advancements are taking place in the cardiac imaging. Out of these, that LA strain and strain rate has gained importance because this is an important biomarker of HPF, which is a very challenge for diagnosis. So, it has been seen that it improves the diagnostic accuracy by showing the abnormal LA strain at rest as well as with leg raising. And it's an important prognostic marker also, because lower absolute reservoir LA strain value was noted in the patients with previous hospitalization who were receiving the ARNI. This was published in a prospective comparison study of ARNI with ARB on management of HPF trial. However, this is the way we do the LA strain, but this requires standardization. It's not yet in the routine practice, so but you must know. So this, in short, is the protocol of doing the assessment of the diastolic dysfunction. It's very critical part of the echo examination, but it should be done very carefully, following the algorithm and keeping it simple. Thank you. Hello, sir. Yes, sir. I've just finished. Will you come, sir? Okay, okay, sir.
Any questions like from our audience? Let's start one by one. So, Dr. Yogesh.
No question, sir. Thank you.
Dr. Ghanshyam.
No question, sir.
Dr. Sai Prasad.
No question, sir.
Dr. Anudeep.
No question, sir.
Dr. Bani Q. Dr. Nida Khan.
Yes, sir. No question.
Dr. Jigna Viresh.
Good evening, sir. Hello.
Yeah, Jigna, go ahead.
Yeah, good evening, sir. Sir, just want to know, sir, while measuring LA
Dr.
volume.
Umesh, please silent your mic. Dr. Umesh. Yeah, Jigna, go ahead.
Yes, sir. Sir, as we measuring LA volume, so ma'am said there should not be difference more than 10% in atrial length. So is it also same with the atrial area and atrial volume?
Correct.
Yes.
I think so.
Yeah. There should not be a difference more than 10%. particularly of length.
Length as well as volume also.
Volume also, yeah.
Okay. And other question is in the formula, LA volume is 0.85 into A1 into A2 divided by L. So, sir, what 0.85 indicates what? Like why we are?
It's a formula given after various studies, they have studied, and this is a standard formula. Like,
It's a
Okay.
constant, like pi r square, pi is
Yes, sir.
3.14, so is a constant is 0.85.
Okay, okay, sir. And sir, grade of DD is applicable for young children like below 18 or not, ma'am?
this is for the adult population.
Only for the adult population. Okay. And ma'am, can you please show me again how to measure propagation velocity?
Yeah, I'll show. Sir, I'll go again to this.
Yeah, please share your slides and go ahead again.
Yeah. So this is the one you were telling about.
Yes, propagation. Yeah, yeah, yes, this.
So see what it is actually. This we measure the velocity of the propagation of the blood from base of the LV to the apex of the LV. As the blood enters to the LV after opening of the mitral valve, the blood moves from base to apex, right?
Yes.
We will be measuring the propagation of that flow, how fast the blood is moving from base to apex. And for that, we take the help of M mode, not the pulse wave Doppler. So how do we do that? We go to the apical 4-chamber view, put the color flow on, and place the cursor right in the middle of the flow. Your AP 4-chamber view should not be foreshortened. It should be bullet shaped. Then only you can make the cursor parallel to the mitral inflow. And as you do so, then after that, you start the M mode, not the pulse wave Doppler. So if you do the M mode, the pattern will look like this. The first wave, second wave, first wave, second wave. So fast forward flow is the isovolume, the rapid rapid flow, that initial E wave flow, that is the fast rapid filling phase, then the second rapid filling phase. Now, in the first rapid filling phase, we will measure the propagation velocity. That is the, we will measure the slope of these. Where to where? Now, from the mitral valve level, can you see the mitral valve here, whitish
Yes,
structure?
ma'am. Yes, ma'am.
Also, it's there.
Yes,
so we
ma'am.
start from there, and then we go deep inside the ventricle, right? The blood
Yes.
is in the ventricle. So how far we'll go? In the book, it's written an AC guideline. You should go up to 4 centimeter.
4 centimeter.
This slope.
Okay.
You get a velocity. It will be displayed in the machine. So
Yes.
if the velocity is more than 50, it's normal. If less than 50, it indicates diastolic dysfunction.
Okay,
Clear?
ma'am. Okay, ma'am. Thank you very much.
Any more question?
Dr. Ganesh Thomre. Okay, anybody who's interested to answer any questions?
Good evening,
Anupa.
good evening, sir and ma'am.
Anupa, go ahead.
Ma'am, I want to ask, ma'am, why this in this Valsalva procedure, why this A wave E wave is reduced and along with A wave, preserved A wave?
Normally, you said.
No, in diastolic dysfunction, but in Valsalva manner we can differentiate. No, the E wave will reduce along with A wave in normally, but in Valsalva procedure in deceased patients, the E wave reduces and A wave remain the same. What is the reason for that, sir?
Why? What is happening? What is the physiology behind the Valsalva maneuver, you say?
reducing the preload.
It reduces the preload. Then what will happen? Reducing the preload means what?
Inflow will be reduced. Filling pressure will be reduced.
See, okay, I'll show you. So what is your question? I want to just know. I'll show you the Valsalva maneuver. Just give me 2 minutes. Okay. So this you have understood, right?
Yes, ma'am.
Now your problem is with this one, right?
Yes.
What I said, see, this is looking like normal. E wave is more because LA pressure is high. Now with Valsalva maneuver, you are reducing the preload. Now, what is lying inside this pattern?
Uh,
I said something is masked. It's the impaired relaxation pattern.
yes, ma'am.
Because of the raised LA pressure, impaired relaxation pattern is masked, and we are getting E wave more than A wave. Now, the moment we remove that factor of raised LA pressure, it will go back to the impaired relaxation pattern.
Okay.
Understood? A wave
Yes.
has to be bigger, otherwise, how the blood will flow?
Okay.
Understood? E wave is less than the A wave. This is the impaired relaxation pattern.
Okay.
Because of the raised LA pressure, E wave was taller than the A wave. Now we have removed that factor.
Okay.
Understood?
Oh, then the more blood has to be pumped only with this contraction.
Because E wave is less.
Uh,
Understood?
and then A wave has to be high, like that, ma'am.
Yes. Otherwise, how the blood will move?
Okay, okay, ma'am. Ma'am, one more doubt, ma'am. If the patient is found to have early heart failure with preserved ejection fraction, then what should be the management for such patients?
You need to give the diuretics, and the rest of the treatment will depend upon the whether there is hypertension, well controlled hypertension. The patient you should not go into atrial fibrillation. You should take care. All those factors.
Okay, ma'am. Okay, ma'am. Thank you, ma'am.
Any more question?
Ma'am, one question, ma'am.
Yes.
Ma'am, what should be the cutoff for E by E prime to call it elevated
40,
left ventricular filling pressure?
40.
14. Okay.
Yes.
Ma'am, and should this be an average of the medial and the lateral?
Yes, yes.
Annually?
Average E by E prime should be more than or equal to 14.
Okay.
Okay.
Right. Thank you. Thank you, ma'am.
Excuse me, madam.
Yes. Good evening.
Yeah, good evening, madam. Just wanted to ask if such patients coming with breathlessness requiring a positive pressure ventilation, so anything would change because of the IPPV? Means they would be having a positive pressure which would reduce preload and afterload would improve. So how would be the conditions in that case? If it changes?
Now the
If there would be-
IBC, with the positive pressure ventilation, the IBC parameter is a problem. Otherwise, mitral inflow pattern, LA volume index, E by E prime, those will be, same as the.
same as we are about.
Yeah.
So, but if we found a pseudo normalization pattern, which Valsalva would be difficult.
You cannot do the Valsalva. You apply the
that's what
Doppler imaging.
Doppler image. Okay.
Yes.
Thank you.
Any more question?
Ma'am, one question, ma'am.
Yeah.
Ma'am, see, if the patient is in tachycardia and the patient just have a single E wave, so in those patients also we can calculate E by E prime and get an idea of the left ventricular filling pressure.
You can, because but it's better to wait if the patient is very much tachycardic. You cannot measure the E by A, right?
Okay.
The E and A merges together with tachycardia. You should wait. But as I said, in diastolic stress test, the patient walks and lies down, and we wait for a while till the EA gets separated. So that's the to measure the E by A. It is best if the heart rate settles and you measure.
I mean, in cases of atrial fibrillation?
Atrial fibrillation, only E wave. There is no A wave. So E and E prime you measure.
Right, ma'am.
If there is tachycardia, you can't help. You have to, if the patient is in heart failure, there is tachycardia, you cannot measure E by A. You can at least measure E by E prime.
Right, ma'am. Thank you, ma'am.
Anybody else? Dr. Ankan Patel.
Yes, sir. No question, sir.
Dr. Umesh Raju. So if there are no questions, shall we say it? Thank you very much and stay blessed. We'll meet you next week for another session of 45th Comprehensive Course on Echocardiography. Thank you very much, Dr. Debika, for a nice talk. I hope people have learned out of it, definitely, and they practice before they come back to their hands-on sessions.
Yes, sir. How is the COVID situation in Delhi, sir?
It's rising, Debika. Its number is increasing every day, and most of the people, they're not reporting it.
Yes, it's like Omicron, right?
Yeah, it's like, I don't know what's going to happen, but number is rising very fast. Illness is limited.
Again, scared, sir. When will it go, sir?
It will go ultimately, it'll die his own death finally.